Hello, everyone, and welcome to tonight's webinar. I'm Tori, Senior Client Support Specialist here with CE Zoom. We have a wonderful webinar for you tonight, but before we begin, I just want to quickly run through a few housekeeping items. First and foremost, just as a reminder, this is a webinar, so it will require a good internet connection. If you get disconnected, our best recommendation is going to be to rejoin using that webinar link. There's a chat box to the right of your screen. Feel free to use that to talk among your fellow attendees. We'll also utilize that box to share important information during the presentation and afterwards. We'll have a Q&A session with Dr. Miller at the end. Feel free to ask those questions in the Q&A feature at the bottom, but we'll also monitor that chat box. At the conclusion of the course, we will share a verification code, and this code is going to be very important to get your CE for tonight. You'll return to cezoom.com, log in, and find tonight's course under Scheduled Live Courses. At the end, there will be a verify button for you there on your dashboard. Click that, enter the code, and then your certificate will be right there for you. And I'll repeat those instructions at the end when we share that code. But for now, I would like to take the time to turn this over to Leslie. Hi, Leslie.
Hi, good evening, everybody. My name is Leslie Brooks. I'm the Director of Professional Education at Implement, and I want to thank you all for taking the time to join tonight's webinar. We're excited to have Dr. Robert Miller with us, a leading expert in this field. He will be sharing his insights and practical strategies to help you achieve consistent results. Dr. Miller earned his BA from NYU and MA in biology from Hofstra University. He graduated from NYU College of Dentistry, receiving the International College of Dentists Award for Clinical Excellence. He also completed his residency at Flushing Medical Center. Dr. Miller is a board-certified diplomate of the American Board of Oral Implantology, an honored fellow of the AAID, and chairs the Department of Oral Implantology at Atlantic Coast Dental Research Clinic. He also directs the Center for Advanced Aesthetic and Implant Dentistry in Delray Beach, Florida, and co-directs the Pacific Implant for Advanced Dental Education. Please welcome Dr. Miller.
Thank you, Leslie, and good evening, everyone. It's funny that you mentioned that I'm chairman of the Department of Oral Implantology at the Atlantic Coast Dental Research Clinic. In the lower left here, you see our brand new building. The state of Florida, after over 40 years, decided to build us a new facility. And that building is a $43 million research facility. We have the entire second floor there. It's better than any dental school you've ever seen. And I'm so proud of what the state has done for us, recognizing the efforts that we have made in our community and the contributions we've made in our community to advancing the art and science of implant dentistry. So, some of you may have been to one or more of my lectures in the past. And you'll see some content that you've seen before. However, I always put some new material in there for you, new videos, new content, and try to frame it in a different way than I have before. Because I know that if you're gonna watch my lecture, you don't want to see the same lecture again. And I've done that in my entire career. I was just going through my library, and I found the announcements from my first lecture from 30 years ago. And it was amazing when I read through it and I looked back and think 30 years of doing this, 30 years of clinical practice, 40 years of clinical practice, and 30 years of lecturing, and how much more we know, how much deeper our understanding is of the biologic pathways and the choices that we make. And that's what I want to really dedicate this lecture to tonight, which is regenerative choices in ridge augmentation, which is a biologic rationale. Not a prosthetic rationale, not a feel-good rationale, not a rationale because you saw some clinician on a podium somewhere use it, so you want to emulate that, and that's what you use. No, this has to be a cerebral pursuit. It has to be something that you consciously look at and say, what is my intended goal? How do I get there? And what materials, what paths do I take to get me there, to ensure a predictable and a consistent outcome and get the quality of the tissue that I need to get me my final goal. So I do receive a speaker's honoraria from the company Implant, but I have no other connection. I don't get I'm not in the sales force. I don't get any compensation for that. And the disclaimer is you must be aware of any of the potential risk of incorporating any of these techniques. Again, this is a cerebral pursuit. I'm going to show you the biology, but you need to plug and play. You need to look at this and say, all right, in the future, I'm going to make my decisions based on certain criteria. And a good part of that criteria should be the biologic rationale. So if we want to understand the key biologic factors in bone regeneration, ridge augmentation, either before or at the same time as implant placement, is something that has the highest complication rate in oral implantology. And while a failure is a failure, and all failures are ultimately failures of biology, you may look at this and say, well, it's the same thing. It just failed. Well, it's not, because it may give you the clinical impression of a common pathway, but in fact, they may be very different. It may be related to the type of graft you use. It may be the type of membrane. It may be lack of surgical skill on your part, lack of experience. It may be because of a deficient soft tissue complex. Maybe you don't have any keratinized tissue. Maybe you have a very shallow vestibular depth. And then we have to understand the local factors prior to that. If it's an infected site, how do we deal with the infection? Do we remove all the offending tissue first and then go in and graft? Or can we just remove everything, graft at the same time, maybe even place implants simultaneously? Well, you need to understand how to control your tissue complex. And part of that is the use of biomaterials. So we're going to compare and contrast the different combinations of materials, look at what the dentogingival complex means, and then understand how we compress treatment time by using things together to get what we call a synergistic outcome. And a synergistic outcome, using two or more dissimilar materials, and then getting an outcome that is better than using them independently at times. So if we look at this chart, this chart really represents the sum total of all of the grafting experience that I have. And I've used literally every single one of these things. Autologous materials, tissue bank materials, xenograft materials, and then synthetic, alloplast. And I will say this, and I say this to our residents in our program, there's no such thing as a bad graft material. It's just bad applications. And if you end up with a less than stellar outcome or a complication or a failure that is biomaterial related, it's not because the material was no good, it's the way you used it, the way you applied it, the way you mixed it, the way you hydrated it, the way you delivered it, or the way when you re-entered perhaps too soon to get good quality bone. And that's why we need to understand the biologic rationale. We look at this. This came from social media. Now, if we look at this, obviously this is the root defect from an extracted molar. And here's a graft material that was placed. Now, if I told you that this radiograph was taken, say, 3 months after this graft, you would say, well, Robert, just give it time. It'll turn over, and then you'll be able to place an implant there. But suppose I told you it wasn't 3 months, it was 3 years later. Now what do you think? Well, this is a graft material that's not going to turn over. It's 3 years later. And I wouldn't feel comfortable placing an implant in this site because implants don't integrate to graft material, they integrate to host bone. So your choice of graft materials, now if I'm not going to place an implant there and I want to maintain my ridge outline, that's the perfect material to use. It will never resorb, and therefore that ridge will never shrink. Where is that good? It's good under the pontic of a fixed bridge, so you don't get food impaction, or it's good under the intaglio surface of a hybrid restoration, an all-on X. So you don't end up with a space underneath your hybrid, and you don't end up with food impaction. So that's a good choice. But that same material in the position where I'm going to be placing an implant then becomes a bad material. No, it's not a bad material. It's just used incorrectly. And this is what we find. You use a relatively non-resorbative material, and all you end up with is a fibrous encapsulated mass. And there, Carl Misch, the late great Carl Misch, had an affectionate name for this. He used to call this hydroxycrapatite, because that's exactly what it is. It doesn't function to grow bone around this implant. and therefore this is a failure. In fact, it failed so badly that it caused the balance of the lost, and then the entire implant had to come out. As opposed to this. This is one of my cases. I re-entered after 4 months to find a whole lot of particulate left at crest. I had beautiful closure, beautiful primary closure, and yet when I re-entered, there's still a significant percentage of graft left. Now, what is this material? This is cortical, part of a cortical cancellous bone graft. So the cancellous component resorbed and was replaced, but the cortical component was not. And therefore, I ended up with a relatively poor percentage of vital bone. Also, one of my cases. Now, in this case, there's no particular graft material left. However, this is not bone. It's somewhere in between, which means that this started the process of becoming bone, but never became bone and left it in a fibrous state. This is called fibrocartilage. This is the precursor to bone, but it never beyond that because the chemistry of the material was wrong. Perhaps if I waited a little longer, it would have turned into a good stress-bearing lamellar bone. So where are we in grafting today? There's a huge array of biomaterials. You go to a conference. I just came back from ADEC in Dubai, the largest dental conference in the world, even bigger than IDS in Cologne. And it was 3 days, and they literally had thousands of exhibitors there. You spend 2 straight days just walking the exhibit hall for just once, just to see them. But there's such a huge array of biomaterials with varying degrees of success. And then when you look at this, what should we accept as the clinical efficacy of a grafting procedure? What is your metric for that? And after you choose the material, what's the best way to prepare it? With sterile anesthetic solution, with saline, with whole blood, with autologous plasma or autologous serum? What do we use? At the same time, you also have to balance how easy it is to handle and to place, how much it costs. You want to be spending $1,000 just on biomaterials. If you were to buy BMP, it's $850 to $1,500 a dose. If you buy Gem 21, which is platelet-derived growth factor, it's $450 for a little bottle of fluid. Then you have to add that to your graft material. So you have the bottle plus your graft material and then the membrane that goes over the top of it. So it's easily $1,000 just in grafting. Is that worth it to you? And what kind of outcome will you get? So is it resorbable or is it not resorbable? Well, again, it depends on what you want to do. If you want to place an implant, don't place non-resorbable. It's not going to turn over into bone. Same time, if you want it under the intaglio surface or a pontic of a fixed restoration, don't use a resorbable material. So there's no bad materials, just bad applications. There's a dense crystalline or low crystalline, or even for that matter, non-crystalline, because that's going to affect the resorption time. How soon do you want to go back in to place your implants? I know we're always in a rush. Patients don't like to wait. Once they start the process of a case, you're doing a full complex case. You don't want to be waiting 6, 8, 10 months after grafting just to place your implants, and then have to wait for that to heal, and then go on. It could be a year or longer, a year and a half before you're finished with your case. Patients don't want to wait that long. So your resorption time becomes important. What type of cellular response is it? Is it solution-mediated resorption? Is it cell-mediated resorption? Solution-mediated resorption is the way most bone in our body is turned over. The osteoclast comes in, secretes an acid, it melts away the bone. That bone then resorbs and leaves traces of two things: bone morphogenic protein and free ionic calcium, which then induces the osteoblast behind it to start laying down bone. So if we get a material that's non-resorbable and those osteoclasts keep attacking it, now you have to go to cell-mediated resorption, where they gang up in this huge multinucleated giant cell reaction, which is a foreign body reaction. And guess what you get when you get attacked by those kinds of cells? You don't get bone, you actually get soft tissue, fibrous tissue, which is like the first video I just showed you. Fibrous encapsulated xenograft, fibrous encapsulated biowasp particles that the body tried to resorb through cell-mediated resorption. What's the quality of the bone at the time of implant placement? What's the percentage of vital bone at the time of implant placement? And what's the percentage of vital bone after integration? Does it continue to get better quality because now it's loaded and stimulating the bone? So if we look at this, and this is what we did for decades, probably the last 50 years or so. You take a particulate, maybe you put a few drops of venous blood in there. You take the particulate and you start pushing it down into the extraction site defect. You keep adding material again and again and again, pushing it down so there's no gap inside. It gets kind of messy. You have to worry about salivary contamination. And once you fill this up, you can't leave it just the way it is. You have to protect it. You have to protect it. As soon as the patient closes, it'll be contaminated with saliva. The bone graft material will extravasate, and then you'll get salivary contamination. So after we fill this up with the bone graft material, what must we do? We must use a collagen membrane. And we cut it to be about 2 millimeters or so larger than the defect. Then we place it over the graft material, and we tuck the margins underneath the flap circumferentially. And then with a very careful suture technique, with a mattress suture technique, we suture over the top of it, either an X over the center or 2 railroad ties or a combination so that the membrane doesn't come out prematurely and you protect the graft. Because it's going to take, with this material, probably 3 to 4 weeks for that tissue to close over the top of this. But if you've got good surgical skills, you've got a good experience doing this, you can get a pretty decent result, but you have to wait for everything to heal. So here we are covering with a collagen membrane, and then we use a nice suture technique, which is horizontal mattress suture that goes over the top. I'm going to skip the rest of this, right? But what happens when we graft? What happens when we do everything to the best of our ability, skill-wise, procedurally, and then we end up with something that looks like this. Now, this came from social media, and again, I must congratulate the clinician who did this case. He did a beautiful sinus graft and placed 2 beautiful implants with a 3 and a bridge. But if I told you that this graft was a 7-year post-op of that sinus, is there anyone watching tonight who will call this bone? Well, it's not, because it doesn't look like this. It should after 7 years, for sure. That means it's all still graft material. So I must ask you, what does this contribute to the health and longevity of this case? And my conclusion is nothing. It's superfluous. It's not even it wasn't even necessary to do this graft. There was enough vital bone here to use a shorter implant and maybe just intrude the apex of the implant by a minor sinus lift without even grafting this case. This just became an exercise. Now, this is what this looks like. This is a cross section of a sinus. This is the zygoma. This is the ridge. This is the palatal plate. And then a graft is placed with the implant. This is the graft. This is vital bone that's growing. But what happens is, because this is not vital bone, it's primarily graft material, over time, over a short period of time, they fail. And this is a failure. This is what we have here is granules of a xenograft held together by connective tissue. And this is a failure. And for all the great surgical that you have, it's meaningless if it fails. And the failure was you chose the wrong graft material for the sinus graft. That's a shame. And here's another case. You want to see what it looks like if you remove it. This is a bilateral sinus case that a periodontist here in Florida did. And after 3 years, he said, "I'm sorry, I can't place implants here. This did not heal properly." Bilateral sinus revisions. This is the upper left. I'm going to show you what this material actually looks like. I'm going to do a standard classic oval window, raise that window, and this is the material inside. Right? This is not bone. This is an amorphous mass of graft material held together by connective tissue. There's no vascularity here. There's no cellularity here. How do you expect implants to integrate into something that's not bone, that's not alive? And I can sit here and literally peel this material out. You'll see how soft this is. All right, so the clinician had decent surgical skills to be able to do the sinus graft, but use the wrong material. So I'll re-raise the sinus membrane, and then I'll choose a graft material that will completely resorb, and then additional posterior implants can be placed. This is the multinucleated giant cell. This is the reason why you get connective tissue rather than hard tissue. This is a case I just did a couple of days ago. A failing implant in a case I inherited to do a revision on a failed all on X. And we're going to be removing this. And in this case, because there were no walls, I must use a particular graft material. It wasn't predictable enough for me to use one of the bone plugs that I have. So I did use a corticocancellous bone graft in this case. And then you'll see me covering it with a collagen membrane. And that collagen membrane that I used in this case is OsteoFlex. Very nice membrane to use. And here it is. I'm just condensing the corticocancellous graft material. And then you'll simply take the OsteoFlex collagen membrane, cut it a little larger than the defect itself, and then tuck the margins underneath the flaps circumferentially, and then suture this. And then a lot of these cases, we could even get primary closure of this, which is amazing to me. But you do want to tuck this underneath the flap margins. All right, now just take your suture material, and I use a combination of mattress and interrupted suture. Here's a mattress suture. Look at the beautiful closure I get with a single mattress suture. And then two more interrupted on the two ends there. And then this case will heal in the end. So the clinical outcome, as I mentioned before, should be the regeneration of vital host bone. So there's two concepts I want you to understand. One is called repair. The other is called regeneration. Repair fills in a space, but it doesn't grow bone. Regeneration, the material resorbs completely and is replaced with host bone, which ultimately becomes stress-bearing lamellar bone. But when we use a graft material, how can we be sure that it's going to give us the final predictable and consistent outcome that we want? Well, most bone graft materials are just osteoconductive, meaning they act as a scaffold for bone cells to grow around it. Blood vessels and bone growth goes around it, and then ultimately it gets resorbed three-dimensionally. But certain materials that do resorb, if they're calcium phosphate materials and they resorb and even resorb completely, have a very unique component to them. And that is when calcium phosphates dissociate, they release phosphate ions and calcium ions. So now the question is there a contribution from the release of free ionic calcium? And in fact, there is. Not only is there a contribution biologically, that release actually makes these grafts osteoinductive, which is amazing to me. And this is a representation of a cell. This would be the cell lining. This would be the endoplasmic reticulum. This would be the nucleus of the cell. And on every cell membrane, there are receptors. This particular receptor is a BMP receptor. And that BMP receptor is sensitive to BMP 2, 3, 4, and 7, which are the pro-growth BMPs. When those BMPs reach the receptor releases chemicals that go into the endoplasmic reticulum. They go down into the cell and they upregulate cellular metabolism. Which part of the cell? The mitochondria. All the building blocks in our body, soft tissue, hard tissue, all starts at the mitochondrial level. So for upregulating mitochondrial activity, we're going to end up with more of the target tissue that we need, actually compressing the wound compression. Now, this is an orthopedic study, and this white column represents the culture without calcium. And the HOB, that's human osteoblast, the MG63 line, which is an osteosarcoma line that we use in a research laboratory to test osteoblast activity, and then our mouse and rat osteoblast. No calcium, the white column is how many osteoblasts are present. The black column represents how many osteoblasts are present when the right amount of calcium is being released by a bone graft material. And we can upregulate that up to 500% if we have the right chemistry. So, if you want to have more bone producing cells, more osteoblasts, use a calcium releasing material. But even better than that, if we look at this study, this is also an orthopedic study, where they looked at two different strengths of calcium in a solution, a 1 millimole solution and a 5 millimole solution. So this was 5 times the amount of calcium as the other one. Then they measured what mitochondrial activity would be at 5 minutes, 10 minutes, 60 minutes, 2, 6, 24, and 48 hours later. Amazingly, the 5 millimole solution at only 5 minutes gave a 400 to 500% measurable increase in mitochondrial production of early proteins. So, we have 2 studies. First study shows you can get up to 500% more osteoblast. Second study, this study, shows that you can upregulate mitochondrial metabolism 400 to 500%. So now you have 500% more osteoblast producing 3 or 4 or 500% more early proteins. You can imagine what that does to the graft complex. And in terms of bone turnover, graft turnover, and new bone formation. This is what we want. This is what we call osteoinduction. You want to see what it looks like in a human trial? This is one of the few human trials you'll ever see that really test the clinical efficacy of calcium. And this is one of these authors is Adriano Piatelli, editor-in-chief of the European Academy of Osseointegration newsletter. And what they did in Italy was they did full maxillary reconstructions with the proviso that 2 of those implants would be explanted at 2 months and looked at histomorphometrically. So we had 2 identical implants, one from the right side, one from the left side, all the way in the posterior. The only difference was one was just acid etched and the other one was acid etched plus had calcium infused into the titanium oxide surface. This is the test implant, just acid etched. Average percentage of bone to implant contact, no real bone turnover. It's in a steady state at 2 months. A little bit of loss of crestal bone. I could show you 1,000 implants on the market today that have this exact outcome. Now let's look at the same implant with the calcium releasing surface. Wow. This is, look at the bone turnover here. Look at the activity. Look at the percentage of bone to implant contact. Look at the level of the bone at the crest. We put them side by side. Virtually no crestal bone loss. Look at the percentage of bone to implant contact. Now, this is the same patient. This is not taken from different patients. This is the same patient showing a massive qualitative difference in clinical outcome when you have a calcium releasing material. So what is the ideal calcium releasing biomaterial? Well, calcium phosphates are, but there's a particular one that I'm using now because of the way it's manufactured and put together. It has a collagen substrate, It has an embedded graft material, which is a non-ceramic, non-crystalline calcium phosphate material. It acts as a collagen membrane at the same time as it's allowing bone growth. It acts as a barrier to epithelial invasion, prevents particulate migration from the grafted area, unlike particulate graft material alone that you didn't have to cover with a collagen membrane. And this is what it looks like in its different forms. It comes in strips, it comes in bone matrix, it comes in bone plugs, it comes in blocks. So we wanted to maintain volume while the graft resorbs. We wanted both the contribution of the graft and the collagen to bone growth. Now, this is interesting because I was just talking a moment ago about the release of free ionic calcium and how it upregulates osteoblast metabolism. Great. But what does the osteoblast produce that becomes bone? Does the osteoblast produce bone? Well, that's what you're taught. The bone producing cell in the body is the osteoblast. No cell in the body produces bone. It produces the precursor to bone. And the main precursor, 90% of what the osteoblast produces, is collagen. Type 1 collagen. And that collagen then undergoes a precipitation reaction external to the cell, and that's where the bone actually starts to crystallize, not within the cell. So if the osteoblast is releasing more collagen, you'll have more of a matrix onto which you'll get a precipitation reaction. So by providing the identical type 1 collagen in your graft material, now on day one, you literally have all of the material necessary for the body to produce bone. You have a calcium releasing material, which makes it osteoinductive, brings more osteoblast in, upregulates their metabolism. And then you have the collagen present for that precipitation reaction where calcium ions and phosphate ions coalesce, they crystallize into calcium phosphates, and then they start to grow. The bone starts to grow. So having both of them are extremely important. You want it to be porous and hydrophilic. You want it to absorb blood components, and it can be used as a carrier for other things. You can add growth factors to it. You can add autologous things to it. But this is the particular material that I'll talk a little bit about today because it is unique. There are many collagen plugs on the market, and I've used all of them. In fact, I still use them from time to time for hemostasis in certain patients. But where I want a rapid turnover of bone, that bone graft material into the highest quality bone that I can regenerate, this is actually some of the material that I'm using today. So it is a very unique material. So the graft material is actually embedded inside here. And it has a beautiful chemistry that releases just the right amount of calcium to get that initial induction, and then just the right amount of collagen, type 1 bovine Achilles tendon collagen, to act as a matrix for the precipitation reaction for new bone to grow. And then we can look at the literature. Alveolar ridge preservation utilizing composite grafts by cone beam dissection. And we look at what ridges look like after extraction without this kind of graft material, and then what they look like after using this graft material. Look at the additional mass cross-section of this when graft materials like this are used as opposed to not being used. And also we want to know that if we're going to be using a material, that it's going to be conducive to cell migration and cell proliferation. So what we see here is 1 day, 3 day, and 7 days, and cellular proliferation on graft materials. This is xenograft, very poor cell migration and proliferation. And at up to 7 days, look at cell migration and proliferation on this material, as opposed to biowas collagen. So we look at the research summaries. We look at this compares favorably or outperforms most of the graft materials on the market today. So if we want to look at, say, single tooth extraction. And the defect is too large to place an implant immediately, or you don't want to place the implant immediately. You want a better quality of bone to cut down on the numbers of complications and failures that you have. All right, we want to generate bleeders in this case. We want to compress the material. Look how it absorbs blood components as you press this in. And then we push this down. We don't have to push it down to the bone level. We just have to push it down so that it's about 2 to 3 millimeters underneath, apical to the gingival margin, because this is a collagen membrane and you have to leave space for those gingival cells to grow across. If you have this at the same height as the surrounding gingival margin, it blocks the access that those gingival cells have to grow over the top of this. And then we do a nice, so here's a little video showing how we do this. I've just extracted this tooth. First thing we do is we want to make sure we're removing all of the pathology from this. So we're going to curette as much of the pathology as we can. Anything that's adherent to the walls, any apical cysts, any apical granulation tissue. And if you want to go even farther than that, you can use rotary instrumentation. You can use a piezo surgery unit. You can use an ablative laser. I love lasers. This happens to be the BioLase I+, which I've been using since 1997, an outstanding instrument for the final debridement. But note, when I'm cleaning this out, look at the condition of the bone. You don't see medullary spaces here. It's dense cortical bone. And it won't bleed. So therefore, we must decorticate this. And again, I don't care what you use to decorticate. Here I'm using a piezo surgery unit. You can use a drill. Whatever you have to make sure that you're getting bleeding points. You want to see those little red dots there because that's where the early blood supply is going to come from. And then we're going to go ahead and place, I'm just going to irrigate this a little bit. Make sure there's no debris down here at the bottom. And then I'm going to place my OsteoGen bone plug. And you're going to see how quickly it absorbs all of that beautiful fluid that's there, all the blood that is contained down at the bottom of this defect. All right, now look how quickly that material is absorbed into that collagen plug. And that you can see the crystals of bone that are contained inside here. And then we just want to press this down, and you cannot overcompress this because it's collagen. It's making sure it's filling with blood. If it's not bleeding, don't put the plug in. Decorticate until you get bleeding. But I can't leave it like this. Otherwise, those gingival cells cannot grow across. So I'm going to compress this down until it goes 2 to 3 millimeters subgingival. I don't care if that it's at the crest. It doesn't have to be at the crest. It can be well above the crest. But it must be below the tissue if you want that tissue to go across. And then we're going to suture over the top of this. You're going to use a horizontal mattress suture to hold it in place so it doesn't extravasate. And then you can put a little gel or something over the top of this. But this is just like having a collagen membrane now. That material is not going to come out. Now, this is a different case, same tooth position, just a different patient. I'm going to show you a 1-week post-op on this. Again, I've just placed my plug. There's my suture, my horizontal X suture over the top. Place a little gel on the top of it. Now I'm going to show you a 1-week post-op on this case, which is truly extraordinary. Look at the quality of that tissue. Look at the thickness of the tissue. Look at the lack of inflammation. No bleeding. That graft is almost completely closed now over the top of this. And I'm going to get a great clinical outcome for this. And then if you want to use suture techniques, here's again a horizontal X suture over the top of this plug. But I'm going to show you a gel right now that I strongly recommend that you use. This is called OxyGel. It's from the OxyFresh Corporation. It's aloe vera with chlorine dioxide. It helps to prevent salivary contamination for the first hour or so while that fibrin clot is really well. And then we look at this. Well, here's some of the membranes I just mentioned that I use if I have to use a membrane that's there. Now let's look at this radiographically. Unlike particulate graft materials, this material does not show up as very dense. Now, I know you like to get that feedback when you place a graft, especially if you're doing a sinus graft, you see it well compartmentalized. I don't like that. I don't want to see that. And the reason I don't is that if I'm using a very dense radio opaque material, how do I know when that material is ready for implant placement? What's my metric there? I don't know. How would I know if it's bone or whether there's still a whole lot of graft material? Here is slightly radiolucent, and then what happens over a period of a couple of months, 2 to 3 months, it starts to look like this. Look at the densification of this right now. That's that is now bone that's grown in here, and it's actually forming trabecular spaces in here. That is my feedback. That's my metric. Now I know that I'm ready to go ahead and place my implant. So if we have facial plate loss, the collagen matrix acts to maintain the osteotomy architecture, prevents the collapse of ridge architecture. It certainly prevents the invasion of fibroblasts down into the graft material. It's a collagen membrane. Prevents food impaction, prevents percolation of fluids into the grafted area. It's so dense. What do we do for teeth that look like this, that are multi-rooted cells? Do we have to have a separate plug for each one? No. We can actually take one of these plugs, cut it to represent the roots that we're taking out, and literally deliver this graft and fill all three of those root defects, the osteotomy defects, with one graft. And just press it in, and then you're going to see how the blood, the venous blood, starts to fill the graft material. All right, then you just take a little bit of a plugger, but I can just do it with my finger. You can see the blood coursing up through that graft material right now. That's what you want to see when you're placing a graft. Then again, just press that down until it goes slightly below the tissue level. Do your horizontal matrix suture over the top. These cases heal unbelievably. This is a 3-month histology, just to show you that it is, in fact, an OsteoGen case. Here's a couple little crystals that are still there, still turning over. But look at the organization at 3 months. It's forming stress-bearing lamellar bone at 3 months. We're not waiting 4 months or longer, as we do with particulate graft material. We can use it as an onlay graft. We can deal with this. We can use it not just to fill a defect, we can use it as an onlay graft for horizontal, for vertical. Now, this is a case where that lateral incisor is going to be lost, but if I place my implant all the way down, I'm going to have a tooth that's too long. So I've placed the implant in its proper position. I've used the tissue punch. I've punched through the collagen membrane. And then I'm going to lay this over my ridge, not just for horizontal growth, but for vertical growth as well. And then it's very easy to co-adapt those flat margins. But the beautiful thing about this is that this material will not migrate. It's got really good body to it. You just shape it, mold it into the position that you want. You currently reposition your flap over the top of this, and these cases heal beautifully. So I'm going to show you uh, a case now that's a single tooth. I want you to use this for the types of cases that you're going to be doing most often. You know, I know everybody wants to rush in and do these massively complex cases, but you know what? Uh, they're tough cases to do, and you don't want to be doing this all day long. It takes a lot out of you. The vast majority of the implant cases that you're going to be doing, is extraction and grafting, or extraction, grafting, and immediate implant placement. So I want you to take the few concepts I just gave you, and now we're going to apply this to an extraction site because I call this my trifecta. What I mean is I have three different materials. Type 1 collagen from bovine Achilles tendon, which is identical to type 1 collagen in the human body, identical to the collagen that's released by the osteoblast that begins the process of producing bone, combined with a calcium releasing graft, which is a non-ceramic, non-crystalline calcium phosphate material. So it dissociates very quickly and induces more cells to become osteoblast. And then we can even apply some growth factors to it if you want to use autologous plasma or something, or just venous blood if you don't have autologous plasma. Venous blood is good. Here's a failing endodontically treated. Here you can see the fistula. It was already retreated and it failed again. Uh, we're going to go ahead and remove all the pathology that's here. Make sure you are removing all of that pathology. And then clean it out in any way that you want to, by rotary file, surgery, and laser. I don't care how you do it, but you must do it. And then taking these plugs and delivering them into the roots. Here we're starting on the distal root. Again, compressing it down into that anatomy. Doing the same thing to the anterior root, the mesial root. Doing our horizontal mattress suture over the top of this. Skip the rest of this. This is the immediate post-op. You see what I mean? That it's relatively radiolucent. You can even see that I've placed the graft material supracrestal. It's below the soft tissue, but it's above the bone level. That's the immediate post-op. This is the 1 month post-op. What's amazing at 1 month is, look at this. I actually got bone to grow coronally. This was above the current bone complex because I placed that graft above the bone, below the tissue, but above the bone. Also, look what's happening. The lamina dura from the extraction site is starting to disappear. How many times have you seen after grafting, months later, sometimes even years later, the original lamina dura, the scar from that extraction site remains, but it doesn't when we use this material because it's so active, you get rapid turnover of that bone. Look at the 3 month post-op. Look at how homogeneous this bone is. No loss of crestal bone. This is ideal. This is a beautiful type A ridge, ready for you to place your implant. So now let's look at re-entry here. I'm going to go ahead and measure this. And I measure this with a perio probe. I actually have a 12 millimeter wide ridge. No collapse of the alveolus after placement of this material. And when I re-enter, I thought, well, I don't know what I'm going to find. Maybe I'm going to find a lot of particular graft material. But guess what? It's all hard bone. It's all hard cortical bone. But look at the vascularity of that bone. You don't see particulate. It's 100% vital host bone. Drill my osteotomy. You'll see the bleeding in a moment. That's at 3 months. Placement of my implant. This is a 6 millimeter wide implant. With 3 millimeters of bone on both the facial and the lingual. That's pretty incredible when you think about it. Then we place our healing abutment and then close this. That's what it looks like immediately post-op. And this is what it looks like after loading. Now, The bone continued to grow coronally on here. You never see this in implant cases. And the clinical crown is just virtually the same as the clinical crown in the adjacent molar. And this bone continued to grow and densify up to the top of this implant. Pretty amazing because of the vascularity of that bone. Look at how beautiful this bone is. So, in conclusion, composite grafts facilitate the grafting process. Look how much easier it is to use a bone plug or a bone matrix strip as opposed to particulate graft material. As soon as I started using this, and not only did it save me time in surgery, it actually gave me a better clinical outcome. It helps to maintain ridge architecture. The last case showed you beautiful maintenance of a 12 millimeter wide molar ridge. No collapse, zero collapse. It resorbs at the same rate that autogenous bone is produced. Extremely important because at the time that you re-enter, and we're re-entering on average 3 months and finding that quality of bone instead of 4 or 5 or 6 months later in these big defects. You eliminate the need for membrane coverage because it is a membrane. It's a membrane built into the plug. So you cannot get fibroblast ingrowth proliferation within the graft particles, and it prevents those graft particles within the graft complex from extravasating. It protects from both sides. We were able to achieve ideal bone mineralization and density in the least amount of times. If it's a really small defect, sometimes I'm going in at 2 months, 2.5 months, literally half the time that I used to go back in. However, because we're not getting primary closure over the top of this, we never use a cytotoxic post-op mouth rinse. The worst one is chlorhexidine because it gets absorbed by the tissue and re-released for 8 to 12 hours. Great if you want to deal with periodontal disease. Horrible to live cells if you're trying to keep a graft site clean. And that includes alcohol-containing mouth rinses because they're both cytotoxic. Never use chlorhexidine or until the wound is closed. Once it's closed, you can go back to using these things. If you're using whole blood rather than autologous serum or autologous plasma, if you're a PRF user, if you're not a PRF user, then you're going to be using whole blood. But I want you to think about this for a moment. Again, it's biology. When you extract a tooth, and then you have the patient bite down on a piece of gauze, how long do you have the patient bite down? At least 15, 20 minutes, hopefully about a half hour. And why do we wait that length of time? Because that's how long it takes a red blood cell blood clot to form and become mature enough so that it doesn't rinse right out. So if you're using whole blood, treat it exactly the same way that you would an extraction site without a graft. Take not a wet, but a damp 2x2, have the patient bite down on that, and have them close for 15 minutes because we want that red blood complex to then form a fibrin clot. It's going to take at least 10 to 15 minutes for that to form, just like it would in a wound without a bone graft. You can mix an antibiotic with a graft material. I just did one of these cases literally a couple of hours ago. My last patient of today was extraction of a maxillary molar in like an 85-year-old woman. I put a few drops of aqueous metronidazole into the graft material so that she would not have to take a post-op antibiotic. A really, really great idea. It cuts down on the consequences of patients taking antibiotics parenterally, by mouth, because it now doesn't upset their microbiome. It doesn't give them overgrowth of yeast and other pathogenic bacteria. Doesn't mess with the digestive system, and yet it's extremely powerful because you're delivering it right into the area of infection. If using post-op antibiotics, While most people would think that amoxicillin is the drug of choice, in an infected site where there's suppuration, yes. An extraction site that's not visibly infected, no. The drug of choice in these cases is azithromycin, which is a Z-Pak. Why do I say that? Amoxicillin is purely antibiotic. Azithromycin is antibiotic and anti-inflammatory. So if we want to get a good result, inflammation for the first 1 to 3 days is good. Late inflammation results in profound graft resorption with very little bone growth. And that's the reason why sometimes you'll graft a big complex, and over a period of a few months, that graft just resorbs away and produces nothing. That's what chronic long-term inflammation does. And what azithromycin does, it prevents the formation of M1 macrophages, which is related to resorption and infection control, and it makes them go to become an M2 macrophage, which is related to tissue growth, the development of granulation tissue, the first tissue that forms before bone is formed. And it's cost effective, it's easy to handle, easy to place and suture in situ. So it's rare that you find a material that speaks to so many different pathways, from ease of placement to site control, site maintenance, to the quality of the tissue that you regenerate, and at the same time being extremely cost effective. You're not going to spend, you don't have to buy a particular graft material plus a growth factor plus a collagen membrane, where your cost could be anywhere from $500 to $1,000 to do a single graft in one of your cases. This is the most cost-effective material that we have, and it's so easy to use. I almost feel like I'm cheating. And when I'm lecturing on this, clinicians say, "Well, do you charge less for this because it's easier to do?" And I smile and I say, "Hell no. They're not paying me for piece goods. They're not paying me because I use a less expensive material. They're paying me for my clinical outcome. And what is that worth to a patient? When a patient gets referred to me to regenerate a site and then ultimately to place an implant, they want success. And I'm using these materials because I get consistent and predictable success with the highest quality of bone that I can regenerate, and then they leave very, very happy. So my referral base is very pleased at the outcome that I get for them. And these are, and you can take a picture of this if you'd like, or a screenshot, whatever you want to do. These are some of the codes that we use, the CDT 2025 codes. So if you're working in a practice where you're doing a lot of insurance work, these are the codes that we're using today. So it covers bone replacement for ridge preservation, bone graft with tooth removal, bone replacement, a peri-implantitis, sinus augmentation, both lateral and crestal approach, guided tissue regeneration, biologic materials. This is really the full range of CDT codes that we have for you. And with that, I say thank you. It was exactly an hour from the time we started. I like to be punctual when I do these things. This is my email address, drrjmiller1@aol.com. If any of you ever have any questions, if you're troubled by a case that you're doing and want some help in terms of treatment planning, or if you have an outcome you didn't expect and want to send me an email, I'll be happy to look at that for you and help you out. And with that, I will turn this back over to Leslie for any questions that we may have.
Thank you so much, Dr. Miller. That was great. Tori, are you okay with me asking a couple of questions here that are in the chat?
Absolutely.
Um, okay, first one is I read a few studies that says adding antibiotics to graft material has no difference with control. Do we have any studies to prove the benefits of adding antibiotics?
Well, absolutely. And you go to the Ziv Mazor Joseph Chacroun study from almost 15 years ago in the ICOI journal Implant Dentistry. We did split mouth studies in the sinus. Uh, One side was just the normal bone graft material, and the other side was the same exact bone material with a few drops of aqueous metronidazole. And what we do by using the metronidazole is we prevent reinfection from gram-negative anaerobes. The number one cause of post-op sinus infections are actually gram-negative anaerobes. And you see little gas bubbles, and as they grow, the gas bubbles get bigger and bigger. You can see in a CT, same patient, side by side, one side and the other side, one without metronidazole, one with metronidazole. And it's clear that the side with the metronidazole in place is qualitatively better than the non-antibiotic side. Now, that's just for sinus grafting. Now you go across the whole spectrum of grafting procedures, and most of the infections that we get are actually from gram-negative anaerobes. So I don't know what literature you're reading, but if you read the right literature, you're going to be a whole lot better off because there's clear defined pathway to preventing post-op infections by using not hydrating with, that's the key. We don't hydrate the graft, we just use a few drops and mix it well. And we do that because the pH is acidic and we don't want to degrade the bone graft material by having a precipitous drop in pH. But a few drops, qualitatively, we can demonstrate a pronounced effect in terms of clinical outcome.
Great. Next question. Would you recommend, it's a two-parter, would you recommend OsteoGen plug when the buccal plate is missing? And also, do you like to use doxycycline during socket preservation after the extraction?
Okay, first let me address the antibiotic side. Doxycycline, which is a relative of tetracycline. Uh, Tetracyclines, the whole family of tetracyclines, which is tetracycline, doxycycline, minocycline, actually interferes with the calcium phosphate bond in bone. So you're actually delaying it is antibacterial, but it actually delays in early bone growth. So we don't use the tetracycline family for this. That's why we went to metronidazole. And two, I forget now. What was the first question?
Would you use the OsteoGen plug when the buccal plate
Okay,
is missing?
thank you. Yes, we do. It depends on the degree of loss. And that then we qualify that by saying how many walls are left in the defect. Because the ideal defect, if you extract the tooth, the ideal defect would have 5 walls. Mesiodistal, buccal lingual, buccal palatal, and apical, 5 walls. Most often, the one that's going to be missing is your facial plate because that's going to be the thinnest in a lot of type 1 tooth positions. If it's a Miller type 1 defect, which is a little tiny narrow crevice, this can be used. If it's a type 2 Miller defect, we're a little bit wider, you still have the wings of bone, you can still use this. If it's a type 3 Miller defect, where those facial wings are gone and there's a depression that goes in at the ridge, then you need to have a space maintainer because this is not going to be around long enough to maintain that space to regrow bone.
Great, great. I missed one here. What's your opinion about using gel foam right before placing a bone graft?
Gel foam to do what? Right
I
before
mean, it's a
placing a bone
clot
graft?
stabilizer, but I'm not quite sure if somebody could type in there if they had any explanation of that. Shri?
Well, I mean, I've used gel foam a lot of times in the past, but not as a graft material because it resorbs too quickly. Literally within a day or so, it's gone. Now, if
It
you want to
looks
use
like
it
they're using it
underneath, if
right
you want to use it
before.
internally, that's fine. But the final material should be stable. You cannot use gel foam at crest. You can certainly use it at the apex. That's not a
Oh, okay.
problem at
So
all.
he's explaining also, he says to create a scaffold for the osteogenic process, which we really don't need.
No, not with this material. You don't need that at all.
Okay. For extremely larger sockets or defects, would you recommend a xenograft plus autogenous bone?
Well, now you're looking at the Istvan Urban paradigm. And I know Istvan very well. He's a great oral surgeon from Budapest. If you look at his history, he actually started with xenograft alone. He started with Sasha Jovanovic using 100% Biowas, and they failed miserably. Then he tried all kinds of combinations. He tried up to 50-50 xenograft and allograft, which also failed horribly. And then he went to 50-50 xenograft autogenous bone, which started to work very, very nicely. And one day I was at a lecture with him and I said, well, Isfan, why not 60-40? Why not 70-30? And guess what? A year later, he actually cut down on the amount of xenograft that they used. Why use a xenograft? Because that is the space maintainer. It doesn't resorb. The problem with xenograft is that the higher the percentage of xenograft, the lower the percentage of vital bone that you get in the end because it doesn't resorb. So if you're using a 50% xenograft, that means that's 50% of your space that will never turn over into host bone. Why do you want that? By using something that's going to resorb completely, I will get 100% vital bone in the highest percentage that I can get. But remember that it's related to the number of walls that are missing, so existing or missing from your defect. If you have sufficient number of walls where that graft is going to be protected by current bone, you can use that material alone. If you have a three-walled or a two-walled or a one-wall defect, then you have to use a space maintainer along with it, whether it's a collagen membrane, titanium mesh, uh, printed titanium meshes, Curi bone plate, cortical cancellous bone, whatever it is. You have to use something else to maintain that space because you're growing bone from very few walls and you have a large vertical and horizontal defect that you have to maintain. This material will not help you without a space maintainer.
Okay. Do we always place sutures if we do a bone graft?
Well,
Let's just talk about, maybe we'll just, talk about here with the OsteoGen bone grafting plug.
which one the suture in this case is meant to prevent the material from extravasating, from coming out. So we're really just placing a horizontal mattress suture over the top to keep the plug in place. Because after a couple of hours, that fibrin clot is going to be so firm that it's going to be impossible for that to extravasate. But it's really meant for the first few hours of healing while that fibrin clot matures around it. After that, it's really not necessary. I can literally remove that in a day or two, and it wouldn't have any consequence because the fibrin clot would be mature enough. But I always use some kind of suture to prevent extremity because you never know what a patient's going to do when they leave the office. I can do everything perfectly, and the patient, and if you've been in practice long enough, patient returns in a week and it looks like crap. Nothing to do with what you did. That's the patient compliance side. If the patient has poor compliance and does all of the wrong things they're not supposed to do, they'll ruin everything. It doesn't matter how well you conceived and executed that procedure. If they're not compliant, it will fail. That's why I use sutures.
Great. Okay, last question. It's regarding the OsteoFlex membrane.
Yes.
What do you like best about it? Because it's a pericardium membrane,
Mhm.
do you like that about the stretchability or that you could suture through
It
it or
conforms
leave
it
it?
conforms very nicely to the graft complex, and I like it even more when I'm using a rigid space maintainer, whether it's titanium mesh or tenting screws or something like that, because it conforms when it's nicely, it drapes nicely over the top of it, and it picks up growth factors, whether it's venous blood or any material that I hydrated with, autologous serum, autologous plasma, PRP, whatever you're going to use. It hydrates better than any of the other collagen membranes that I use.
Okay, last one. When this is it, I promise. Do you recommend resorbable or non-resorbable sutures with the OsteoGen bone grafting plug?
Makes no difference because even if I use a resorbable suture, I'm always removing them in 1 week anyway. And I'm not I don't have to. It's just that all the patients complain after a week. The doc, these sutures are killing me. They're flopping around. They say, oh, don't worry, I'll just remove them. Because by that time, everything's closed. All the epithelium is growing over the top. I don't need them anymore. But if the
Great,
patient for some reason can't come back, you're not going to see them for several weeks, sure, use the resorbable material.
great. Tori, did
Uh,
you want to do some closing?
Yes, let me share that verification code with everyone. It is in the chat right now. Let me just pull this up. There we go. So you should be seeing that code on your screen now. It is T2PRVBTG. Again, you will need this code to get your CE for tonight. Return to CE Zoom and find tonight's course under scheduled live courses. There will be a verify button next to it. Click that, enter the code. The capitalization will matter, so it is case sensitive. So you can either copy that right from the chat box or write it down or take a screenshot right now. Take the mandatory survey, and then once you do those 2 steps, your CE certificate will be there for you. And of course, if you have any questions during that process of getting your CE, please reach out to us at help@cezoom.com. And with that, I will dismiss everyone. Everyone is welcome to have a wonderful evening. I am going to leave this code up for another 5 minutes or so, or until I see the room empty, but everyone have a great evening.
Thank you so much. Thanks, Dr. Miller.
Sure. Thanks, everybody.
Good night.
See you along the way. Bye.